Hello, oral surgery colleagues, and welcome to the Oral Surgery Podcast. I am your host, Dr. Richard Moore, an oral surgeon based in the United Kingdom. The aim of this podcast channel is to discuss ways of improving practice in oral surgery, thereby creating a better journey and patient experience, and allowing us as clinicians to become better oral surgeons. All discussions on this channel are based on personal experience and opinions, which should be thought-provoking and supplemented with further research and evidence-based practice. Without further ado, let's jump into this podcast. Hello everybody and welcome to this podcast. I'm joined today by Robbie Williams, who's an oral surgery registrar and implant dentist on the Wirral, which is the northwest of England for those who are international. So hi Robbie.
Hello.
And we're going to have a chat tonight about, because Robbie's quite unique in the fact that he's not only an oral surgery registrar, but a part-time one, or less than full-time training is the approved term. But he's also done a lot of implant work and has done his master's dissertation looking at antibiotic prophylaxis during dental implant placement. And his iconic paper is a couple of years ago in the British Dental Journal. So I'll put a link to that in the in the podcast info. But so yeah, I guess Robbie, if perhaps you can just tell us all a bit about your background in implants and what you get up to on a day-to-day basis, and then we'll have a chat about the research.
Yeah, no worries. Thank you very much. So as you said, I'm soon to hopefully end my oral surgery training in June, so in a few months' time. But I've been doing that part-time over the last 5 years, 60%. So 3 days a week I've been doing my oral surgery training in a hospital in Arrow Park on the Wirral, and 2 days a week I've carried on doing initially it was GDP work, and then it just basically more and more grew into solely kind of private oral surgery and implant dentistry. I started out, as I said, doing it was 1 day a week when I was a staff grade before my registrar job, doing NHS dentistry, and at that point was applying for registrar posts. Didn't ever know, or didn't truly know, whether it would ever come to fruition with how competitive it was. But I knew that I sort of enjoyed the thought of implants and thought that was quite a good sort of way of taking my career if I didn't ever get into oral surgery training. And, if I did, they'd complement each other well. So that was about 5 or 6 years ago, I think it was. So it'll be 6 or 7 years ago actually now. So I decided to basically, alongside being a staff grade and a dentist, do a master's in implants to try and cover all the bases and get as much knowledge as I could at that stage. And then, while still having a hand in practice, had the opportunity to develop doing treatments outside of the hospital.
I think it's you're not lucky, I guess, but certainly part of the oral surgery training, there's a huge void of implants, isn't there? And I think that's one of the issues with training, and it varies where you are. Certainly our trainees don't get much exposure for various reasons, but it is a core component of oral surgery, and we tend to see, perio and restorative specialists doing more and more implant work, which I think gets a little bit frustrating for some of us, especially when you've gone through oral surgery training thinking, well, hang on a minute, you can restore them, but I'll be doing the surgery. And it should be a team approach, really. So, I think you've done really well to get all of that together and now come to the end of training successfully. So, the world will be your oyster in some respects, or maybe the Wirral's your oyster, I don't know. But so you did the masters. Now, obviously, you as part of a masters, you will choose a research project, and your title was antibiotic prophylaxis and implant placement.
Yeah.
What stimulated that, other than it being controversial?
It basically came about because I think when you're trying to learn anything new, you kind of want someone to tell you exactly what to do, and this is what you should give. And I found that every mentor that we had through the MSc would kind of recommend a different regime, which I thought was kind of a bit odd. And then, the master's teaching that we got was kind of referenced the Cochrane review, which we'll probably talk about, but kind of said, oh, it's not very good, or not against the Cochrane review, but the evidence it's based on is not particularly strong.
Yeah.
And then, as you go around the implant circuit, more and more people, when I started to ask them about what they did, seemed to do totally different things. And I just thought this was crazy. And I also, coming from the oral surgery background, I've done quite a bit of oral surgery by that point, in my career. And we do pretty big stuff and don't give antibiotics and don't see many post-op infections.
Yeah.
And that
Yeah.
also sort of intrigued me as to why, for this fairly clean, procedure with a sterile implant and a single site and all that kind of stuff, we're giving antibiotics. And sometimes it was, 24 hours before and a whole week after. It was, 8 days worth of antibiotics with some people's regimes. And it just fascinated me to know what was going on.
Yeah, I mean it's unbelievable, and I do wonder if because the majority of implants in the UK are done privately, whereas I guess the majority of oral surgery is more NHS based. Are people practicing defensively? It's difficult to know, isn't it? And we'll probably never know the answer to that. But it is interesting. We'll come on to your paper in a sec. But so I guess the evidence that's out there. You've talked about the Cochrane review, which was 2013.
Mm-hmm.
So that really didn't give. I mean, some people refer to it and say, well, there's some evidence there, but I guess that was probably a starting point, was it, for
Yeah,
your lit
exactly. And
review?
I have to be totally honest with you that when I started this project, that was the only. I'd never sat and looked it up myself, and although I've been asking mentors what they did, I never actually sat down, which you probably should do, and did a literature review myself until it came to this paper. And that was the only real big piece of evidence that I knew about and had been taught. And so I didn't know at the time the FGDP guidance, for example, referenced implants. Admittedly, it's one paragraph in the whole document. It
Yeah,
was before it got revised, and it wasn't a particularly helpful one. But that was there, but I didn't know about it. And it turns out a lot of other people didn't, from my research.
yeah.
Um, and there'd been several, probably better or based on better evidence, and possibly arguably more usefully analysed systematic reviews of meta-analysis since the Cochrane review. Um, with
And that's since your paper, is it as well? Or was that kind of same time?
Well, both. So yeah, just before we chatted, I thought I'd see what was around because it's been a year or two since I've properly again looked into it, and there's been probably since the Cochrane review there must have been about, I don't know, 10 to 15 more systematic reviews of meta-analysis. So there's loads and loads of papers looking at this,
Yeah,
but not many good randomized controlled trials, which is why they all come up with very similar conclusions,
yeah,
and we're not getting that much further down the line with it, to be honest.
yeah. Okay, so let's have a chat about your paper and what you looked at, and it was purely UK based, was it?
Yes. Yeah.
Okay, so I had a read of it earlier just to recap because I did listen. I think you present at BAOS a few years ago,
Yeah.
and
Yeah. And
that's
I
the first time
presented
I.
the same paper at the ADI National Forum as well, which was really good because that, it's the ideal
Yeah,
audience to speak to, really.
I mean, I was just going to say what is AD? I'm not a member of ADI at the moment. What's their take on antibiotic prophylaxis? Do
There
they have
kind of
any?
isn't one, really.
Okay,
And I think that's one of the things I'm sure we'll talk about later is, where do we go with this? I think it's going to take somebody like the ADI to adopt a stance on it and
okay,
almost like publish a guideline. I think to make a consensus across the profession, because I think, yeah, it's something that needs to be done. But they don't have any. They've never passed comment on, as far as I'm aware. There's no sort of statement or guidance out there from any of the sort of national implant associations having a stance on it, really.
yeah, okay. So basically, in summary, the Cochrane review suggested a number of 25 needed to treat.
Esposito's was 25, yeah. So you have to
Yeah,
give 25 people antibiotic cover for one of them not to have a failure.
yeah, which is a lot, isn't it?
But well, so you say that, but that's the lowest that's come out of any of them since. So the rest, there was two more a couple of years later, systematic reviews that reckoned 48 and 50. And then everyone else has kind of fallen in between, depending on
Yeah.
how they've analysed the data. So 25 is the least. It's probably more nearer 50.
And I guess the flip side of this is, okay, potential implant failure, but is that as catastrophic as somebody having C. diff or
Exactly.
anaphylaxis? And I
Yeah.
think for those people that listen to Wendy Thompson's podcast with me, certainly that there's a huge emphasis on that. And I do wonder if we're really have that in the back of our minds when we prescribe, or whether we do give too many antibiotics. And I think we definitely give less antibiotics for infections. I'm sure we consciously do that, but for things like implants, I'm not convinced that practice has changed. But anyway, your research is going to tell us the answers, really. So you surveyed BAOS, British Society of Perio, the Prosthetic Society, which has got a huge acronym,
Yeah, yeah,
ADI, and an ITI, interestingly.
yeah,
And you had quite a good. Well, I guess it's difficult, isn't it? Because there's no, as you say in your paper, there's no database of implant. It's not like having the oral surgery specialist list and we can do a power calculation on this. So we don't know how many people are placing, but it's going to be a lot, isn't it?
yeah, exactly. And that was frustrating actually. And I tried so hard to get data. I was trying implant reps. I was trying companies like how many people buy your implants, just to try and get a rough ballpark figure, but it's just impossible.
Yeah.
And yeah, I mean, the similar kind of paper was published in 2012 in the BDJ. It's very similar to mine that Prof. Ireland did. And he's very generous with sharing some of his data and questions and things. So I kind of, and I didn't know, again, I didn't know that paper was there till I looked into it. And I sort of based mine as an updated version of that, really. And it's helpful to do comparison. But I was hoping, we got 229 responses, which is reasonable.
Yeah.
I have to say, I was really hoping for more. I was hoping people would get on board with it, considering how many societies had sent it out to their members. But if
It's
that's
always the
just the
case.
nature of
Yeah.
questionnaires, isn't it?
Yeah. And I guess when did you do it? It's pre-COVID, isn't it?
Yeah, no, it was
Yeah.
2018. It was, yeah.
Yeah. So there's no excuse really that people were bombarded with questionnaires, but it's the same with everything. You never get what you want unless, well, I don't know. I don't know what the answer to that is,
Well,
but
just
yeah,
the thing is, it comes into people's consciousness, and they probably think that's a good idea. I'll fill that out, and then it just disappears to the bottom of the
disappears.
email list, doesn't it? And,
Yeah, with
you
everything
can't just
else.
keep pestering people again and again. And so
Yeah.
anyway, so we got 229 responses. Excuse me. And which was about double what they got in 2012. So that's pretty good. And yeah, I asked them all kinds of questions, trying to get as much data as you can, really, about who are they, what do they do, how long have they been placing for, how many do they place a year, what kind of placements do they do, training, what kind of courses they'd undertaken in implants, and then obviously then more about what antibiotic regimes do they give. So I asked sort of four things. I asked both pre and post-operative regimes, and then for non-penicillin allergic patients and penicillin allergic patients, to try and get a good idea of how things differed.
Yeah. And it's interesting reading the
Yeah,
paper.
um, as I say, 229 people responded, and across the kind of pre-post-op penicillin, non-penicillin allergic, I got 61 different drug dose combinations. So that's kind of, amoxicillin, whatever variant, and then the varying doses. But they were prescribed across 124 different regimes.
Unbelievable.
So, for example, one person would give 3 grams of amoxicillin stat, whereas another person might give it an hour before, whereas another person would give amoxicillin 250 milligrams 1 hour before, and then someone else would give the same, but starting at 24 hours before. And it's just crazy. If you look at my data collection of the regimes, it's just embarrassing to see the variation in practice. That's the best word to describe it. It's
Yeah.
crazy.
It's worrying. And I don't think it probably hasn't changed much since you published this, I don't imagine. I don't know what your...
I don't see any reason why it would, but it's, and also one of the things which I think is going to be a struggle to get this to change is that if it's been working for people, they're very reluctant to change.
Yeah. Because you've only got to change your regime and then have a failure.
Exactly.
And instantly you'll associate that failure with that regime change, won't you?
Yeah.
And there'll be no evidence really for it. It's anecdotal, really. So definitely people need to read the paper, having a look at it, and it's just also the perceived benefits that people responded to is
Yeah. So
quite
again,
interesting.
yeah, and I asked them, exactly like you say, I said, well, why do you give antibiotics, or why don't you, for that matter? And also, what kind of factors might impact upon your decision to give? And um, yeah, a lot of people thought that antibiotics, or gave antibiotics for with the intended benefit of preventing post-op infection.
Mm.
In fact, I think it was 75% of people. Whereas actually, again and again and again and again in the literature, it's stated that that's not borne out by evidence. Almost every systematic, I think every systematic review that's been done has shown no difference in post-op infection. Um, they have shown reduced implant failure, which again, I mean, I'm interested to talk about this with you potentially. It's always fascinated me as to why does this happen. It clearly does, because lots of studies have concluded this now. But if there's no post-op infection, but the implant doesn't integrate,
Yeah.
but it's not surrounded by pus, that's not an infection. So why are antibiotics
Well,
helping?
yeah, and it's
I'm not questioning whether they do, because obviously there must be some
mm,
effect there. But it's just, as I've always, that's one thing that's always bugged me, is what's going on. I don't.
and and I guess the majority are amoxicillin. They're
Mm.
not using something that's more highly absorbed by bone, or it's fairly broad spectrum, and it is really interesting. And I yeah, I mean, is your take up is your current practice to prescribe then following this, or are you?
So I try my best now to keep to kind of current guidelines, and also the evidence I've read, and for a healthy patient in a straightforward single unit case where there's no grafting and it's
Yeah,
just a healed site, no question about it. I don't give it, but I talk to the patient about it,
okay,
and I tell them why I'm not giving it. And most of them are absolutely. I've never had anyone question it. Um, but if I couple of multiple, if I'm, let's say, a couple of implants in a similar situation, I probably still wouldn't give it, but have the conversation.
yeah,
Um, but in anything that involves bone grafting, or anything that's a slightly more complex patient, or
yeah,
a compromised site, or if I'm going in early and there's previously infection, or anything that's off
yeah.
totally straight and narrow, I do give a pre-op dose, yeah. And if I have to admit, if I'm grafting, I'll often give a post-op dose as well.
So what would you go for? 3 grams of amoxicillin
I give
pre-op?
two, purely because, again, it's just the lowest effective dose, really.
Yeah, yeah, I give 2 as well. And
Uh,
post what, like an hour before, or just stat?
yeah, an hour before. Yeah,
Yeah. And if you give a post-op dose, is it 5 days or
yeah,
3 or
exactly.
yeah,
Yeah, 5 days. Yeah.
yeah. And your choice for penicillin allergic, do you go with clindamycin?
So, well, I do, until I listen to Wendy's talk. Yeah, and and also, actually, I'd not come across this before, but reading a few recent papers, there's a bit of a thing out there in the literature now that is questioning whether clindamycin is associated with an increased chance of implant failure. Um,
Oh, that's interesting.
yeah, having read the papers, I'm not sure it is. I think there's a bit of a cause and effect thing going on here, that it's probably just less effective at preventing them, rather
Yeah,
than. But some papers have actually gone as far as to sort of preach caution with using clindamycin,
interesting.
until more research is done. So yeah, I mean, I do use clindamycin. I have to say, I've not noticed any failure problems with relating to that, but it's an interesting thing, isn't it?
Yeah, and nobody's come back with C. diff that you know of.
Not yet, no. No, but that week I'd done it. That I'd listened to Wendy's podcast. I'd given a lady pre and post op, because I did quite a big graft on it, and I was sat there thinking, "Oh God, she better not get C diff now."
I'll just give her a call.
Yeah, it does make you think,
check,
though, doesn't it?
check
But
she's
having
okay.
said that, I do always say to patients whenever I use clindamycin, because I'm paranoid about it, if you get
Yeah,
any upset tummy, just stop taking it.
yeah, yeah. Don't hesitate. And I guess the other, I mean, and this is obviously we're probably working on similar lines and similar guidance, which is good to know. But also, the one of the other outcomes of your paper was that the desire for guidance from your respondents was over 90%, well, 91%.
Yeah,
And I think that's really important. So there's obviously a need and a demand there from practitioners
yeah,
for whether it's ADI, BAOS, whoever, to produce something that is that can support our clinical practice, because it's all a bit woolly, really, isn't it? At the moment,
yeah,
it's not overly helpful. And I don't know. It'll be interesting. I've hopefully got somebody lined up to talk about medical legal stuff. It'll be interesting what their take is on it. If you had an implant fail in a fit and healthy person that you'd not given any antibiotic prophylaxis, is there an argument that actually you probably should have done, and
Mm.
would it have been successful? And I think that would be a really hard argument, or difficult argument to prove. But I could be wrong with that.
That was, I gave people the option to expand on their answers, and the clear sort of comments that were made with regards to some people said they gave it, weren't quite sure if it was efficacious or not, but
Mm,
felt too lacking in confidence not to. Kind of, one person said, I didn't want to put my head above the parapet and not give it because everyone else seems to.
yeah.
Um, and yeah, but then interestingly, other people didn't want guidance because they felt it took away their clinical autonomy and that they could be used against them if they didn't follow the guidance, kind of thing.
Mm.
So you can't please everybody.
No, it's tricky, isn't it?
Yeah.
And I guess the other thing that might be interesting is there are so many implant courses out there, whether they're university programs like a master's or their diplomas that are approved up to level 7 and things like that. What they all teach, and I guess we'll never know that answer because even if you surveyed them all, not you might not get. Well, you won't get 100% response anyway, but you may also not get the true reflection of what's taught. But it'd be interesting to see what different programs teach. I did my old school implant training years and years ago, and things like diplomas and MScs didn't exist then, not in implant dentistry anyway. So
Mm.
for us, it was always, but I'm old school. I'm old. We gave everybody antibiotics for everything, whether it was a wisdom tooth or an implant. So things have changed. Definitely, my practice has changed, but it would be interesting to see what people teach, and I guess how that's reflected in other countries. I'm guessing the US is always give, because they seem to for a lot of oral surgery, even if it's just a prophylactic dose. Um, and how that changes in Europe, maybe. So there's another project
Yeah,
for you.
this is not a problem. Also, this is not a problem just with us in this country because there are the papers from all over the world, from kind of Saudi Arabia, from Sweden, Italy, Spain, USA, South Africa, also all showing almost identical levels of variation in practice in their countries, and massive variation between countries. So, we're all
We're all in the same
it's
boat.
yeah, absolutely.
And what about have ITI got a take on this?
Not that I'm aware of.
Oh, well, I wasn't aware. That's why I thought I'd ask you.
Not that, and I have to admit, I haven't recently dug for it, but obviously when I was doing all this, I really, really did dig, and I couldn't find anything. But people might show up with something that's hidden away somewhere that I'm not aware of. But again, the fact we're asking the question shows that it's not. If it's there, it's not well publicised enough,
No.
and that's one of the big problems. Because actually, the guidance in the FGDP new document, which came out, I think it was like a day or two before my paper was published in the BDJ, is much more comprehensive in terms of discussing implants and discussing the literature and giving a bit more of a recommendation. And so that actually is almost enough, I think, potentially.
Yeah.
It's just, again, I don't think people know about it because your day-to-day practitioners who are placing implants don't have this stuff at the forefront of their mind, and unless it's sort of brought to their attention, they may not look it up or know it's even there.
Yeah. Yeah, I mean, it's really. I mean, they clearly say it's controversial, and they we talked about that number needed to treat ranges so broadly from almost 25 to 50. But I think in the back of our minds, we've got to have that consciousness about resistance and antibiotic stewardship, which is should be at the forefront of our minds. But there's no RCT out there that's going to compare prophylaxis against non-prophylaxis. With
Two things there actually, just quickly. Yeah, what one thing is the antimicrobial resistance thing. There was a review paper organised by the government a few years ago, and published on this, just trying to find out how big is the problem, and it's massive. It's terrifying, the prospect. I know we all talk about it, but it's
yeah,
a bit like climate change. It's this enormous thing that's coming towards us that kind of I think we're all happily ignoring when it suits us. But there was a figure in there that struck me that said currently there's about 8.5 million people a year, I think, die in the UK of cancer. But it's estimated that by 2050, 10 million a year will die from antimicrobial resistant
Yeah.
infections. And
Yeah.
that's
And
now kind of 30 years away, less than
yeah.
30 years away. So more people are going to die from antimicrobial resistant infections in the UK than
Yeah.
die of cancer. That's crazy.
It's huge, isn't it? I mean, I think we are. I feel that my clinical practice and people around me have changed, but we perhaps haven't changed enough to make a difference yet. And it's difficult, but we definitely prescribe less
Yeah,
for
I agree with you. And
actively.
also
Yeah,
for dental infections and that kind of stuff, I think it's
yeah,
much, much better than it used to be,
yeah,
COVID aside.
yeah.
Um, but yeah, I think, and if you think of the number of implants that are done a year, though, and
Oh, yeah.
it's a prescription per implant, it's a lot. It is.
It's
It's
huge.
hundreds of thousands of
Yeah.
prescriptions a year, and some of them, are probably worth it, but I don't know whether they all are.
Yeah, I think kind of like the scenarios that you gave, the fit and healthy single placement that's in a healed site, then you shouldn't really, should you? But having that conversation with the patient, and then it's interesting that none of those patients wanted it. Then I would have thought, because I give it routinely for every implant. I'll be honest,
Hmm.
a 2 gram dose pre-op, but I explain. I say there is, the guidance is a little bit. It's not clear cut for you if you're fit and healthy, um, and I'm happy to not give it. But I've never had anybody say, "Oh no, I'd rather not have it." But then I think that's an education thing with the
Yeah.
general population, isn't it?
But
That
I think, and also it's probably how I pitch it to them. I mean, when I tell them my master's dissertation was on it and that I published
yeah,
on the subject, and that I'm probably turning around and saying, "Do you know what? In your case, I don't think it's necessary." Then they all just go, "Well, that's fair enough."
yeah,
But interestingly, I've treated a dentist recently for two implants, both 4 and 5 premolars, and I kind of felt that I wanted to use it for him because he was a retired dentist, and I felt pressure and all that kind of stuff. Which again is probably not right, but that's what most people would. That's probably
yeah.
what's wrong with most people. And he actually said to me, "Well, actually, I'd rather not have them."
Oh, interesting.
Yeah.
Okay, and he's been
Um,
okay.
So yeah, and they took and they're restored now, so it all went fine. But it does just show you. But again, there's no grafting with that or anything like that. And just quickly again, because I just remembered, you mentioned an RCT. So I had a quick look for anything recent, and there was an RCT done in Gothenburg in 2019, which is probably one of the best I've seen actually. So they had reasonable numbers, 224 versus 223 consecutive implants placed,
Okay.
um, either in a pre-op antibiotic only, there was no
Yeah.
post-op, or nothing. And they did see a higher failure rate with no antibiotics given. So failure rate at 4 months, they basically class failure as the implant having to be removed at
Okay.
4 months, which is reasonable, I think.
Yeah.
2.2% if antibiotics were given, or 7.5% if no antibiotics were given.
Oh, that's interesting.
Yeah, and that's made me really think about things, because it's a fairly well designed trial. There's no sort of blinding on assignment, but the surgeons were kind of allocated at random to cases, and when you look at the breakdown of what cases they did, it's pretty well matched the groups. It's not like all of the difficult ones were,
Yeah. Yeah.
high risk cases were no antibiotics. It looks fairly non-biased, but so that's an
Oh,
interesting one, isn't it?
that's worth a read. Yeah.
But that's
Mm.
the kind of thing we need more of. We need
Yeah.
we need more of those papers, and if they come out again and again and show the same thing, we can really, with conviction, say when we do and don't need antibiotics, and we
Yeah.
can,
Yeah. It's really tricky, isn't it?
So they gave 2 grams 1 hour pre-op, by the way, of amoxicillin, or 600 milligrams clindamycin if they were
Clindamycin.
allergic. Yeah.
So I was just about to say before you threw that RCT in that, oh, well, maybe when I do my Saturday clinic this weekend, I won't give antibiotics. But I've just kind of something in the back of my mind's telling me maybe I don't know. Yeah, I need to read that
It's
paper.
really hard, and it's definitely to do with the fact that we're in private practice, and
Definitely. Yeah.
it's a um, well, one in
It's an
five people
expensive
in the
procedure.
answers to my questionnaire, 1 in 5 people, and it's probably more, but 1 in 5 people admitted it, that they did admit that litigation plays a part in their decision to go antibiotic.
Yeah.
And another 1 in 5 admitted that the cost implications of it going wrong also played a part, which I thought was really honest of people. And it's probably higher than that. But, that's the world that we're operating in, isn't it?
It is, sadly. And it's funny because any private, or, if you do a private WYSI, I don't treat them any differently than, from a regime, because it's a private patient, they're going to get some antibiotics, as opposed to a patient I would treat in the hospital on the NHS for a third molar.
No.
And certainly the guys that our implants are done by, the restorative guys, I'm pretty sure they give antibiotics. I need to check that out. But so, yeah, it's
an interesting one, though. I think if one of the societies came out and backed the FGDP guidance, which is you shouldn't routinely give it, and certainly not in a straightforward case, then I think that more people would feel secure about doing it. But there is also the FGDP guidance is there now, and for all to see. And it's an interesting thought that excuse me, the GDC do say that in the standards of professionalism, because this was I think it was in my dissertation, if not in my paper, we are bound to follow evidence-based guidance.
Indeed.
And if we deviate from that, we should have a good reason to and document it. And so actually, if we're worried about not giving it and having a problem, but actually if we give it and a patient gets C. diff, or we give it and a patient has anaphylaxis,
and you've not justified it,
and you've not said why, and it doesn't actually meet with FGDP guidelines, then you're actually just as liable. So it's as difficult as it is. We're kind of almost damned if we do, damned if we don't. Unless I think if you can justify everything, then you're okay, aren't you? But I think it's important that we do.
Yeah, definitely. Yeah, and it's just documenting that and having that. We constantly talk about shared decision making with the patient. I think that's really important as well.
Massively, yeah. I know you talk a lot about that, but I think that's so important.
Yeah, because we're so not negligent. That's the wrong word, but we it's so we'll just give you some antibiotics. Is that okay? It might reduce your infection risk, but we very rarely say. And I'll hold my hands up and say this to say, well, actually, if I give you 2 grams of amoxicillin, there's a small risk you might get C. diff and have a major problem. So that's something that we need to be saying, and probably it may need to go in our consent form, which again I know isn't watertight, but it's perhaps some supporting evidence there that we've had this conversation, as well as in the notes that these are the pros and cons of antibiotics, like any other treatment that you're going to give to a patient. So I think perhaps we do need to. Well, I certainly need to think about changing my practice for that. So yeah. Well, that hasn't cleared the waters for me.
No, sorry. And that's that's exactly how I felt at the end of when I presented it. It was kind of everyone's kind of like, so what do we do? And
Robbie's got the answer.
I haven't got an answer, but
actually,
this is the whole point of this, and the whole point of this kind of podcast, and the whole point of presenting it to people was to make people scratch their heads a bit. And,
definitely.
And for us all to scratch our heads jointly and try and get a bit of consensus in practice, I think, because it's if they work, great, but we should all be using what works, and it shouldn't be. We should have a consensus. We should try and figure out what works, and then everyone should be doing the same. You shouldn't go down the street to or even within the same practice. I know people in the same building in different regimes for the same procedure.
That doesn't surprise me, having worked in NHS hospitals for most of my career. And somebody like ADI or somebody like that, it would be great if they could get their members engaged and everybody maybe produce a database where people can record what they're doing, and we can see over a 12-month period, because there'll be a huge set of data for that.
Yeah.
And any side effects or post-op complications. So yeah, interesting. There's something to consider.
Hopefully someone listening will be keen enough and in a position where they can actually set up an RCT, because I think especially in healthy patients and healed sites, it is, you would get ethical approval now.
Yeah, definitely.
To randomise it, I do think you would.
Yeah. Well, it's been a pleasure, Robbie, and I'm glad we kind of tore that apart and had a good debate. And I will put a link to your paper in the podcast details, so I'll encourage people to read it. And it's been an absolute pleasure. So thanks for spending the time with me and having a chat about your research.
That's very kind of you. Thank you for inviting me on.
All right, take care.
Cheers, guys. Bye.
Thank you very much for listening to this podcast, and any resources will be linked in the description. Please do leave a review and rate the podcast on the iTunes Store. I hope you join me for the next episode. Goodbye for now.